Hello, everyone, and welcome to today's Talking Point presentation. I'd like to begin by acknowledging the traditional owners and the lands on which we're meeting today and pay my respects to their elders past, present, and emerging. I extend that to the Aboriginal and Torres Strait Islander people listening today or in future. My name is Shalini Aranagiri. I'm Clinical Director of the Hamilton Centre and Statewide Services at Turning Point, and also an HMRC Emerging Leader Research Fellow and Associate Professor at Monash University. It's my pleasure today to be facilitating today's talking point called Gender Differences in Substance Use Disorders, Implications for Treatment, and presented by Professor Shelly Greenfield. Talking Point is a regular series of publicly available lectures that aim to inspire, inform, and challenge our notions of what we know about addiction and its impact across our society. We'd like our webinars to be as interactive as possible, so please ask questions via the Q&A function for online attendees. Today, we're also lucky to have attendees in the room with us for this hybrid talk, so we'll also be taking questions from the audience. The questions will be collated and answered by Shelly at the end of the presentation today. Our webinars are also recorded and are later made available on the Turning Point website. So if you keep a lookout on the website, you'll be able to access the recording at a later date. So without further ado, I'd like to introduce our presenter for today. Professor Shelly Greenfield is a professor of psychiatry at Harvard Medical School and the Christine Trusty Endowed Chair of Psychiatry at McLean Hospital, where she also serves as the Chief Academic Officer. Shelly is the Chief of the Division of Women's Mental Health and the Director of Clinical and Health Services Research and Education in Alcohol, Drug and Addiction Treatment at McLean Hospital. She's the Mary Beth and Chris Gordon Fellow at Harvard Radcliffe Institute, where she's studying gender differences in substance use disorders. Shelly is also the originator of a treatment called the Women's Recovery Group, which is a manual-based group therapy treatment for women with substance use disorders. It's an evidence-based treatment, and the manual for dissemination was published in 2016. And it's one of the things we're going to be lucky to hear about today from Shelly. So it's my pleasure to invite Shelly to join us today.
So, hello, everybody. It's really nice to see you all here today, and I am happy to be here with you. Been really looking forward to coming, and I'm glad to share some time with you this afternoon. And hello to people in the room, and also to anybody who is actually listening online. So thanks so much. I'm going to talk to you about women in addiction, science to practice. I want to just let you know that I am the author of Treating Women with Substance Use Disorders, the Women's Recovery Group Manual, and I am going to talk to you about this treatment today. I also want to gratefully acknowledge the NIH, National Institute on Drug Abuse, that actually supported much of the research I'm going to talk to you about today. So first, I just want to start for context, and I like to start by saying that, our research focus on gender and sex differences with a focus on women in health in the United States, it's really a relatively recent field across all health care conditions. We date it back to 1990. And we do because in 1990, our US NIH established the Office of Research on Women's Health. And then it really wasn't until 1994 that our federal government mandated that phase 3 clinical trials supported by the NIH must include women and minorities. So that's 1994. It wasn't until 2016 that our NIH mandated that sex as a biological variable be included in human and vertebrate animal research. So really, we date back this kind of focus by 35 years, which may for some people seem like a really ancient history, but actually really in terms of closing knowledge gaps, it's really relatively recent. And that's across all human health conditions, inclusive of psychiatric disorders, inclusive of substance use disorders as well. So I do like to set that context. And that said, we have known for many centuries that there have been problems with women in addiction. I like to show this beautiful painting by Toulouse-Lautrec. It's of Susan Valadon, actually, who became an artist in her own right. But this was painted in about 1895, and it was in Paris when the Parisian Medical Society noticed an uptick in alcohol-related problems amongst women. So we do know that we've known for centuries that there are problems for women in addiction, but generally speaking, through all centuries, right up until the last decade of the 20th century, we really thought of these as predominantly disorders of men. And then really in the very last decade of the 20th and now 25 years into the 21st century, what we've really seen is over this last 35 years in the United States, and I'd say in Australia and other places as well, there's been a narrowing of this gender gap in substance use and substance use disorders. in the United States and elsewhere with rising rates of alcohol and drug use disorders in adult women. And then we've also seen the prevalence of past year substance use disorders in the US is now greater in 12 to 17-year-old girls than in boys. So what I want to do today is talk to you about some of these recent epidemiologic trends and show you some things about the narrowing of the gender gap of substance use disorders, not just in the US, but here too in Australia. A new study that we are conducting to examine potential correlates of these changes. I'm going to talk to you briefly about risks for substance use disorders and treatment barriers for women. And we're going to talk about the clinical treatment gap and the need for gender-specific interventions for women with substance use disorders that can be implemented into routine clinical practice. So I am going to talk to you then about the Women's Recovery Group for women with substance use disorders. I'm going to explain to you that we had a hypothesis about verbal affiliation as a mechanism of action, which we've actually been able to demonstrate. And then we're going to talk about some digital interventions for women with substance use disorders and some new research that we're conducting at this time. So in the US, this is our National Survey on Drug Use and Health. These are data from 2021, and you can see the blue bars are males, the red bars are females, and what you can see are that males are more likely to have a substance use disorder in the past year than females, but that gap is 1.3 to 1. That's the male to female ratio in prevalence in 2021. In 2001, 20 years earlier, it was 2.6 to 1, so it's narrowed by half in just 20 years. And we see this continuing. But of concern, as I mentioned, is that in 2013, amongst 12 to 17-year-old girls in the past year, the prevalence rates were equivalent in 12 to 17-year-olds. But you can see 6 years later in 2019, girls exceeded boys in past year substance use disorders, ages 12 to 17. And that trend has actually continued. These are the 2023 data just released in October for alcohol use disorders in the past year by gender. You can see here that girls in the 12 to 17-year-old age group exceed boys by almost 2 to 1. Past year alcohol use disorders, 12 to 17-year-olds, girls now exceeding 2 to 1 is the prevalence ratio. So we do know that this is actually real. This is happening. There are many, many different epidemiologic surveys that have actually been demonstrating this. In 1990 in the US, the male to female prevalence ratio in alcohol for alcohol use disorders was 5 to 1. By 2001, it had decreased by half to 2.3 to 1. By 2012, 1.9 to 1. It's narrowed further, as you just saw. It's more like 1.4 to 1 now. And we know that, these are some data from Rich Gruza. Multiple epidemiologic surveys show that women born after World War II had lower levels of abstaining, higher levels of alcohol use disorder. And that was compared to cohorts born before World War II. And what we've seen is every successive cohort, we've seen actually a narrowing of the gap. I also want to talk about the intersection of gender and race and ethnicity for substance use disorders. This is a compilation of data from our National Survey on Drug Use and Health between 2015 and 2019. We'd actually been asking for, could we have this sort of intersection so we could actually see this in one place? And this is a great report that's downloaded. During this period of time, the US overall population, we saw like a prevalence ratio that was at about 1.9 to 1 male to female, but it varied with race and ethnicity. And that's really important. You can see here for people identifying as Hispanic or Latino was 2 to 1, Black or African Americans, 1.9 to 1, Asian Americans, 1.76 to 1, white Americans, 1.7 to 1. But I want to call your attention to 3 groups where it's even closer in our American Indian or Alaskan Natives. That's 1.46 to 1, the male to female prevalence ratio. For people identifying as 2 or more races, 1.39 to 1. And for people who identify as Native Hawaiian or other Pacific Islanders, 1.38 to 1. And the reason it's really important is because this helps us identify populations with vulnerability so that we can consider how best to work with those communities and try to figure out what's the best way to, implement treatments that are going to be most effective and most helpful to those communities. So we know it varies with race and ethnicity. It's not just all one thing, and that's incredibly important. So what about in Australia? Well, these are from your NDSHS. I'm learning to say all those acronyms. And I just pulled these up. These are for people aged 18 to 24. And it's the change between 2019 and 2022, 2023. The light green bars you can see there is 2019. The dark green bars is 2023. And look at how the females have increased. Males have stayed the same for any illicit drug use. Look at cannabis. Females have really increased between 2019 and 2022, males about the same, right? Look at cocaine, same sort of story, pain relievers and opioids. So you can sort of see that you too are having the same exact thing. That's recent data, 2019 to 2020. Look at that. That's, I think, kind of significant in my opinion. This is use patterns, right? It's not. So then take a look at this one. This is 18 to 24. And I just want you to look at the risky alcohol consumption and look at females between 2019 and 2023. Males, it's increased, but not quite the same. So look at how that gender gap has narrowed in like 3 years, which is quick. So, we've all been very happy to see that, seniors in high school, there's been a decrease in their alcohol use and past month use of alcohol, past month episodes of being drunk. But what I want to show you here is that the gender gap here is like completely closed. So it's the same for girls and boys. And here's for Australia, 14 to 17-year-olds. Look at how in 2022, 2023, just look at that. The black line's girls, green line's boys. So you too have crossed the divide here and flipped. This is also pretty interesting that you all collect this data. We don't collect these data. I think this is pretty interesting. It's people who have suffered harms from someone under the influence of alcohol. What you see is that actually females have been more likely than males. Both have suffered harms from people who have been intoxicated, but females are more likely to have suffered those harms than males in Australia. So we know that in the decade in the US between 01 and 12, there was a 16% increase in the proportion of women who drank any alcohol, a 58% increase in women's high-risk drinking, and an 84% increase in women's one-year prevalence of having an alcohol use disorder versus a 35% increase in men. So, you might ask, why do we even worry about any of this? What's the big deal about this? Well, we know that there are many alcohol-related health risks through the lifespan. They include liver disease, brain health and memory, cancer, including breast cancer, cardiovascular disease, and multiple mental health consequences. And that's true for men and for women. But as many of you know, women do experience greater harms at lower doses of alcohol over shorter periods of time, which has been known for many, many years as the telescoping course. And we are already seeing a lot of downstream effects. This is a study that was just recently published about the increase in chronic liver disease and cirrhosis mortality rates disproportionately affecting young women in the United States. Our Surgeon General just published this, Alcohol and Cancer Risk. This is a report that was just put out in January of 2025, essentially like our Surgeon General's report 70 years ago about smoking and the link to cancer. This is about alcohol and the link to cancer. This is 70 years later. This is one for alcohol, not for smoking, for alcohol. And then this is the New York Times talking about increase in breast cancer in younger women in the United States, a big increase. And these are the downstream health effects that we've seen with this closing gender gap and rising rates within women. Telescoping, many of you know that term, but in case not, we talk about this as women who drink progress more rapidly to serious alcohol-related physical and social consequences than their male counterparts, shorter times between landmarks of illness progression, happening at lower doses of alcohol consumed less frequently. And we know that there's evidence of the same kind of telescoping with other substances, stimulants, opioids, and nicotine. But for alcohol, we know a little bit more about the physiology and the why. We know that women have less alcohol dehydrogenase, the enzyme that begins to break down alcohol in their stomach linings, the gastric mucosa. That means we have decreased first pass metabolism for females, a greater absorption of absolute ethanol into the circulatory system. Women have more adipose tissue, lower total body water, ounce per ounce. It's more highly concentrated. That's in the circulatory system, goes around, affects your liver, your brain, et cetera, with heightened vulnerability across all of those organ systems. And as I said, similar findings in stimulants, opioids, nicotine, but we don't have all of the physiology quite like that. So why are rates of substance use disorders increasing in general in women? I think a lot about things like the commercial determinants of health, advertising direct to media, to women, and social media influences. I'm just going to show you that I do think that this plays a role. So in the United States, we have chick beer, little black dress wine, mommy's time out wine, mad housewife wine, We also have Vango Blue. PMS isn't anything a good vodka cocktail and a cupcake can cure. We have Bailey's. We have Skinny Girl cocktails. And this is direct commercial advertising, right? But what we've also seen now is social influencers on social media. We have wine moms, women's wine walks. We have paint and sip, knit, sip, knit. We have all sorts of these things on social media. So even if we could make inroads on, commercial advertising direct to women, social media, there's no way to really control what's going on there. And this is rampant all over social media. And so every place a woman gathers, it should happen with wine, it should happen with alcohol. And we've seen a real rise in this in the last, 10 years. So you can think about whether you think that's influencing anything that's going on. But I would tell you that, in 1973, the tobacco industry designed its very first cigarette for women. And women's risk of dying from smoking more than tripled in the next 50 years and was equivalent to that of men in 2014. So I would posit to you that it does, in fact, play a role, or, industries wouldn't do these things, right? And we see the same thing going on now for vaping as well. So, in terms of other substances, here you have past your opioid analgesic use disorder. You can see that the gender differences are not that big, but look at the 12 to 17-year-olds. Girls are twice as likely as boys in this 2015 to 2019 period to have a past year opioid analgesic use disorder. We also see in the United States rising rates of cannabis use. This is adult women. And then in the 12 to 17-year-old group, you can see also the same type of thing. So again, why is this happening in a big picture way? People have lots of different answers. It's social media, it's alcohol advertising, it's role changes, it's normalization of substance use in women, stress, social isolation, loneliness, legalization of cannabis, more depression and anxiety, trauma, COVID-19 stress and loss. So I've been asking these questions, what are the potential drivers and how might they vary across the age span and across cohorts, right? And, what about other factors, as we talked about, such as race and ethnicity or sex and gender minority individuals? And so I've been undertaking a new study this year with an overall hypothesis that this is really complex and multifactorial. I actually do think it will vary with age cohort, with the type of substance and other significant factors. And ultimately, we are hoping that we will be able to think through some of those things to begin to put together actionable initiatives in treatment, public health, and policy. And so we did design a community survey, which we fielded this past fall, stress, substance use, and mental health in adult women in the US. And the goals of this survey are: the epidemiology is known, we just talked about it. So that is what the what is, right? That's the what, but it's not the why. We don't know the why. So we surveyed almost 2,300 women in the early fall, it's fall for us, sorry, in September of 2024, to describe the potential contributing factors correlated with substance use patterns. So not diagnosed illness patterns. We're looking at heavy use compared to light or moderate use across all substances: alcohol, cannabis, prescription medications, other drugs, and across all age groups 18 to 70. It's a survey of adult women in the community, so it's not a clinical or treatment sample. And we want to understand those patterns of use and look at potential correlates. And why is this study different from other studies to our knowledge? It's because it's all ages 18 and over, multiple age cohorts. It's all substances. It's not restricted to one. It's individuals in the community, not treatment seekers necessarily. And it's all women. It's a survey designed for women based on the things we know, the extant literature in women. Also, we have almost 2,300 people, 18 to 70. It's a robust sample size, so we think we can look at multiple of our hypotheses, but also age cohorts. We can look across age cohorts. And so we just collected all the data. It's cleaned. We're starting the analysis now. So stay tuned, and hopefully maybe I get to talk to you again about that once we have some of our data analyzed. But we're really very engaged in this right at this moment. So what we've talked about right up till this point of the talk is that we know that women now initiate their use of substances at an earlier age than in previous generations, approximately the same age as their male counterparts. We know they advance more rapidly from first use to regular use to first treatment episode, and yet that happens using smaller quantities of substances for fewer years. They can average more medical, psychiatric, and social consequences, the so-called telescoping course of substance use disorders in women compared to men. We also know that women are more likely to have co-occurring depression, anxiety, and trauma-related disorders, and that this actually has impact on the onset of disorders, the course of disorders, and treatment responsivity. So we know those things. So given what I've just talked to you, I want to talk to you a little bit about barriers to treatment, and I want to talk to you a little bit about then the rest of the time, gender-specific treatment for women and the need for that. So in the US, we know for sure that women are less likely to be screened in primary and mental health care. We know that there are a lack of treatment services in the US for pregnant and parenting women with substance use disorders. And in the US, we also know that there are economic barriers that actually get in the way of women seeking treatment. We also know trauma histories figure very largely in whether or not people can seek treatment. For example, if you are a woman with trauma, you might not wish to be in a mixed gender treatment program, but you might not have access to one that would be for all females, just for one example of how that might get in the way. We also know that social stigma and discrimination are high for all people with substance use disorders in the US, and I dare say probably here as well. But we also know that that burden disproportionately falls on women, especially women who are mothers and women who are pregnant and parenting. And as I mentioned, women are also at higher risk for certain co-occurring psychiatric disorders such as mood, eating, anxiety, and PTSD. And that actually can present a barrier to getting treated for a co-occurring substance use disorder, because it's not, as you all know from being here, it's not as common, for those things to be treated in a co-occurring way, which is really very critical and important. So in the United States, in spite of everything I've just said to you, this is a survey of our substance use treatment services. And you can see that 50% will, these are data from 2019, but 50% will serve adult women, 52% have co-occurring disorders treatment, 42% treat trauma, 28% sexual abuse, 28% intimate partner violence, and 24% pregnant or parenting women. So you can see that there's a lack of services overall within the addiction treatment sector in the US. And so what we know is that most women will receive in the US treatment in a mixed gender substance use treatment program. And we also recognize the need for treatment would be great for gender responsive care for women with substance use disorders, given that most will be treated in a mixed gender program. And that was the impetus more than 20 years ago now to begin a research program to develop an evidence-based group therapy designed for women with substance use disorders who are heterogeneous with respect to their substance disorder, alcohol or drugs, other co-occurring psychiatric disorders, depression, anxiety, trauma histories, and life stage. And so we developed the Women's Recovery Group. We developed it in stage 1 and stage 2 behavioral therapy development trials funded by the NIH, National Institute on Drug Abuse. This is a single gender group therapy for women with substance use disorders. It's manualized. It's a relapse prevention group treatment. It has structured sessions and women-focused content. It's an empirically supported, effective, gender-responsive component of care. It can be disseminated, and it currently is disseminated into routine clinical practice in the US, and now actually in 2 pilots in other countries as well. And we've seen new adaptations in the US to military veterans who are women and also to young adults. So I'm going to tell you a little more about some of the results of it and what it is exactly. But I just wanted to show that we've published pretty a lot, both on qualitative and quantitative data. It's a mixed method study. And then in 2016, we published the dissemination manual. So at the beginning, we had this hypothesis about how it would work. And we said that, well, this would have an all women's group composition. So we hypothesized that it would increase group cohesion and affiliation. I'm going to talk to you more about affiliation in a little bit, that it would increase open discussion of triggers and relapse prevention and increase comfort and support. And it would also provide the opportunity for us to provide education about the antecedents and consequences of substance use that differentially affect women, and that these 2 things would synergize and enhance outcomes. So what is it? It's a 90-minute structured relapse prevention group therapy. It has a brief check-in, then there's a review of a skill practice and last week's topic, a presentation of a session topic done in an interactive style, an open discussion by participants, and then a review of the session's take-home messages, and upcoming week's skill practice is handed out, then there's an official checkout. So it's a pretty standard kind of way and format. So we have 14 session topics that can be flexibly chosen. These in the blue font are what we think of as gender-specific topics: the effect of drugs and alcohol on women's health, managing mood, anxiety, and eating problems without using substances, violence and abuse, women and their partners, women as caretakers, women's use of substances through the life cycle, substance use and women's reproductive health, and then the issue of disclosure, to tell or not to tell, that takes on sort of the issue of stigma directly. And then these in the black font are the ones we think of as bread and butter relapse prevention topics. They're infused with a lot of women-focused content, but things like how do you manage triggers and high-risk situations, using self-help groups, et cetera. But in it, there's a lot of women-focused content. And so I'm going to take you through a little bit about, just very quickly, some of the results of the stage 1 and stage 2 trial. The stage 1 trial main results were published in 2007. And this was a very typical psychotherapy development study. We developed a manual, we did a pilot test, we revised it based on what participants said, and then we tested it in a very small trial, randomizing women to either gender-specific women's recovery group or an effective mixed gender group drug counseling condition. GDC is just a standard counseling condition. It was used in the NIDA-funded cocaine collaborative trial. And what we found was, we were trying to demonstrate feasibility and acceptability. We found that it can be implemented feasibly, it was highly acceptable to therapists, and also had high participant satisfaction. But then we also found was that in the stage 1 pilot study, in the 12-week treatment phase, women in both conditions decreased their use of substances in clinically meaningful ways. But what we found is that 6 months post-treatment, it was the women in the women's recovery group who actually sustained their gains, and those who had been randomized to the mixed gender counseling condition did not. So that was enough of a signal for us to go on to a larger stage 2 trial, and we published the main outcome results in 2014 from this 2-site randomized controlled clinical trial. We had 156 participants, 100 women and 56 men. We had 2 sites in 2 very different places within Massachusetts. Women were randomized either, again, to the WRG or the mixed gender counseling condition. This, though, study was like sort of like a combo phase 2, phase 3 study. We just decided that we wanted to show that it could just be, if it worked at least as well as the mixed gender condition, you could just put it right into treatment. We just didn't want to have to run through yet one more study. So we actually designed it so it started in both clinics and it ran continuously for 24 months without a stop, even transferring therapists, just like normal world treatment, where people are coming in and out, coming in and out, coming in and out. And what we asked is, would the outcomes of the women's recovery group implemented in community practice be at least equivalent to the outcomes of effective mixed gender treatment, the group drug counseling condition? We also wanted to make it as externally valid to the community, so that it would, so we had high, proportion of people with depression, anxiety, PTSD, and personality disorders. People had alcohol, opioids, cocaine, sedatives, and cannabis use disorders. And what we did find is that the women randomized to both, either one, actually made meaningful decreases in their substance use from throughout the 3 months of the active phase, and also maintained their gains 6 months post. And we did not see meaningful differences, so essentially a non-inferiority trial, and we were able to demonstrate that it is an effective group therapy for women. It's 90 minutes, it's 12 sessions, it was highly feasible, met with high satisfaction. It could be delivered in routine community treatment in a rolling group format as a gender-responsive component of care in mixed gender treatment. But I also want you to keep your eye on that too, because I'm going to show you something else, because I told you we did a mixed methods trial. But just to demonstrate, the small trial, we showed that the women's recovery group members demonstrated a pattern of continued reductions in substance use disorders 6 months later. And in the larger trial, the women in the WRG demonstrated comparable effectiveness to standard mixed gender treatment, with women in both groups reducing substance use in meaningful ways. So I mentioned to you that we had this theory about mechanism of action, about affiliation, and we wanted to operationalize. We published 2 studies on this. And we wanted to operationalize affiliation. The way we did it was by assessing verbal statements of affiliation in the group, reflecting empathy, support, shared experiences, and strategy, which meant that we put together like a taxonomy of verbal affiliations, and we were recorded and coded all tapes, all tapes. And we then coded them, with coders two different coders, et cetera. And then we looked and we published 2 studies on this, which we showed that we measured group affiliation in both the women's recovery group and the mixed gender GDC as the potential mechanism of action. We taped and coded all group therapy sessions for specific verbal affiliative statements, and then we analyzed these affiliative statements and we compared. And what we found were there were 66% more affiliative statements made in the all women's recovery group compared with the mixed gender GDC. So that was interesting on the face of it, but it didn't mean that. What did that mean? Therapeutically, did it make a difference in outcomes? And so Dr. Linda Valeri, who's a statistician, published this paper in 2018. And what she was able to do is take every single individual who had been in the stage 2 trial, and actually she was able to watch their trajectory through every single group that they were in. Every single group had already been pre-coded as highly affiliative or not highly affiliative. And then what she was able to do is show the 6 months post-treatment outcome based on how much exposure to affiliation you'd actually had. So what she found was there was greater group affiliation among members in the WRG compared to the mixed gender control group. And the more exposure you had to greater affiliation in the women's recovery group, the better your 6 months post-treatment outcomes actually were. So we thought that was pretty interesting. So we concluded this is a 90-minute, 12-session manualized relapse prevention group therapy with structured sessions and women-focused content and an all-women's group composition. It's an effective group therapy for women, heterogeneous with respect to their substance use disorders, their co-occurring other psychiatric disorders, their trauma histories, and their life stage. Greater group affiliation among members in the single-gender WRG. We found that compared to those in the mixed gender GDC control group, and exposure to groups with greater affiliation in the women's recovery group predicted better substance use disorder outcomes at 6 months post-treatment. We also exit interviewed everybody. We did, exit interviews, taped them and coded them. And I want to just show you a little bit of that work of women's and men's experiences in group therapy for substance use disorders. And what we found, we did a thematic analysis of qualitative interviews from the stage 2 trial, 77 women and 38 men. The women in the mixed gender GDC rated group gender composition as significantly less helpful than the women in the women's recovery group. In our qualitative interviews compared with GDC, women in the WRG endorsed more feelings of safety, support, being themselves, opening up about important issues such as trauma, abuse, and important relationships. More men endorsed the benefit of mixed gender groups than did women. Both women and men endorsed guilt and shame, but only women discussed societal stigma and judgment as harsher toward women, especially in their roles as women and mothers. And I'm just going to read to you in their own words what some of the women said about the women's recovery group. A lot of the information that was presented to me, I was very unaware of, in particular women's health, what alcohol does to a woman's body. The education end of it was huge for me, really huge, to the point that I was sharing it with my family and friends. I think it's easier to be frank and more open than I would be in a mixed group. The past physical abuse, I wouldn't talk about those things in a mixed gender group. I think there's a difference in the male-female experience with addiction. There are different reasons, different circumstances, and psychologically different needs that men and women have. I think women support each other and we listen. It's a safer place to have just all women. I think it is a societal perception that women who drink are just bad, sloppy people. Men who drink are out to have a good time. I think it's easier for women to get sucked down by their illness because it's more of a negative for women in society, the way we're looked at. So we just talked about the women's recovery group that we developed in these stage 1 and 2 behavioral treatment trials, that it's a single gender group. It's a manual group, so manualized group, so it can be replicated with fidelity. It has structured sessions and women-focused content. It is empirically supported. It can be disseminated. It is disseminated into practice. In the United States, it's now piloted in 2 other countries, and we have new adaptations for women vets and young adult women. And then what I want to do now is talk to you a little bit about digital adaptations that we've been doing and new research of content from the WRG for adult women and also transitional age women and other mental health conditions, and a new study that we're doing for women with opioid use disorders who are on medications for OUD. And so I'm going to introduce you to my colleague here, Dr. Dawn Sugarman. She is the PI of these studies that I'm going to tell you about. And Dr. Sugarman is dedicated to developing sustainable strategies to integrate gender responsive components of care for women with substance use disorders using digital platforms. So the first study was developed, she developed a gender specific web based intervention for women with substance use disorders. It's a 30 to 40-minute psychoed intervention delivered like on an iPad, connected to the web. And she took content from 5 modules of the WRG, and then she adapted those and what she did in the first study was demonstrate feasibility and satisfaction of delivering this. And I'll show you a little more in a moment. Then, after that study was completed, she did further adaptations for young women, 18 to 24 years old, who had substance problems, but were actually receiving care for co occurring mental health conditions, not for their substance use disorder. And I will show you about that. And I just mentioned she has a new NIDA funded study kind of coming toward the end now for women with opioid use disorders to try to help women who have started medications for OUD stay on their medications. So, as I said, in the first study with adult women with substance use disorder, she first adapted 3 of the modules, and then she expanded and had 5 of the modules, and she ran these. So it's on an iPad. She ran it in an inpatient unit, a partial hospital, and an outpatient clinic delivering this program. So these are women who are getting their substance use treatment, mixed gender care, but they're getting this 40-minute intervention that's psychoed. Then the second study was doing an adaptation for 18 to 24-year-old women who are hospitalized for depression, anxiety, personality related self injury, PTSD, complex trauma, eating disorders, who didn't necessarily identify that they had a substance problem, but the clinicians did identify them and they agreed to participate. And so they too had this, 40-minute psychoed intervention. And I just want to show you this isn't the current interface, but gives you an idea. You're sitting there, you've got an iPad, you're on a busy unit, no clinician time's being used. You just are sitting there with your thing. And it says things like, welcome, for this topic you will learn about, et cetera. Have you or someone you know ever struggled with mood, anxiety, or eating problems? Each of these web-based interventions provide psychoed content, coping skills. They have interactive questions. They provide resources. They do a knowledge check question, and they have take-home messages. And as I said, for the one that was in the mixed gender substance use disorder treatment, we had it was feasible, highly acceptable, and the patients had high satisfaction. And for the young women, um, one thing was really interesting was that it was feasible, it was acceptable, it had medium to high level satisfaction. But one thing we were really interested in is that from the pre to post intervention, these were young women 18 to 24, they significantly increased their ratings of their interest in making changes to their substance use and their willingness to make changes in substance use. So after 40 minutes sitting with an iPad, especially among women who didn't really even identify themselves as having an issue, we did see this change. And again, qualitative participant feedback, you'll recognize this feedback is very similar to what I showed you in the group. Just learning all of this information is crucial for all women. I was unaware of a lot of it. It's really helpful to see the information this way. In groups, it's great to be able to discuss these things with other people, but it's easy to miss something. So having it all laid out on an iPad like this is really helpful to remember everything and also see it visually. And then finally, I was talking to you about this new study, which is really to increase women's engagement in medication treatment for opioid use disorder through a digital intervention. And you'll recognize that there's a digital intervention. It's 6 different topics, just like we were talking about all the modules. So there's 6 topics that are covered. And then these are the 6 topics. And then here is the digital component that goes with them throughout the study period. And so what you see here is that, as I said, these are the topics, which I won't read through them. And then in the 6 weeks post, there's a weekly check-in. There's a skills practice twice a week. There are motivational daily messages that come onto your phone, and there are resources that are always available. And so this is, I think we're up to 32 enrolled people out of 40. and we're hoping to get to 40 by June. So this is work in progress, and we don't actually have the results yet of this, but very much looking forward to seeing those results. So I'm wrapping up now. When you treat women with substance use disorders, it's really important to use women-focused and gender-responsive approaches, which means integrating conceptual and empirical evidence like the type that we just talked about gender differences in antecedents and consequences of addiction and treatment process, to include treatment for co-occurring other psychiatric disorders, for trauma exposure and associated physical and mental health needs, to address the central role that relationships with children, intimate partners, and others play in women's addiction and recovery, and to provide appropriate and necessary adjunctive services. And just to conclude, we know there's a narrowing gender gap in the prevalence of substance use disorders, and that is true in the US, it's true in Western Europe, Scandinavia, Australia, New Zealand, and many other countries. Women born in the last 5 decades have lower rates of abstinence and higher rates of substance use. They have a telescoping course of addiction. We know there are important considerations by gender and race and ethnicity. Treatment outcomes we know can be enhanced by programs that provide services and other programming specific to women's needs. I presented you data about the Women's Recovery Group, a manual-based single-gender women's recovery group with women-focused content. We know it can enhance treatment outcomes, and it can be integrated into community-based substance use disorder treatment programs and other outpatient programs. And we are researching digital adaptations that we think are promising to extend gender-specific treatment to women with substance use disorders. I just want to acknowledge the myriad co-investigators, consultants, group therapists, research study staff, and the generous support of NIDA for supporting the work. These are some of the people who have worked on the Women's Recovery Group over many years. There are others, but these are the ones I have photographs of. And with that, I want to thank you for your attention. And this is the last slide. It's a Q&A slide. So thank you.
You so much, Shelley, for that really, great overview of a tremendous amount of work that's been accomplished over, I think, a really, amazing period of time. I think we're going to get some questions through from the audience coming up in the Q&A. So really great if you're joining us online. If you want to just pop that in the chat in the Q&A. But to get us off started, I was really interested in sort of in terms of adapting the particularly psychoeducation components of the impact of, say, substance use on women's health, how you've kind of thought about that and formulated that over time as well. I'm also aware sort of the evidence base has kind of grown over time, particularly in relation to, say, menstrual health and the menstrual cycle and the impact, I guess, of substance use and withdrawal and craving and that sort of thing. So really interested to hear about how that, you weave that into the recovery group and how we do that.
Yeah. So I'm not sure if I'm supposed to stand somewhere here or where I'm supposed to stand, but so actually the module that's on women's use of substances and reproductive health, that has menopause, perimenopause, and menstrual cycle. And so that module is meant to take into account a whole range of reproductive health through the lifespan. And I think that there are a couple of different things to reflect on. I think one of the things to reflect on is that we do know that those things are very important and impactful, but I will point out that our knowledge base there is pretty bad. Actually, we've reviewed the literature and published a bunch of things in the last couple of years on this, and it's a very messy literature, and it's not really great. We've looked at menstrual cycle and mental health disorders. We've actually just published one on menstrual cycle, estrogen, and alcohol use disorders just last year, I think. And the research is not particularly easy to follow, and it's very conflicting and difficult. And when I started my context here about the fact that we are like 35 years into looking at gender and sex differences with a focus on women's health, and I mentioned that we have a lot of knowledge gaps to close, I would just say to you that this is one of the things I'm really talking about. There's a lot to understand and know that we really actually don't understand and know. And that, I think it's really important because there are sex and gender differences. This is true for men, true for women, and we do need to understand these things better for human health. It's very important. The other thing I would say is at McLean, one of my colleagues who's working with me on the current community survey that we're doing, her name is Laura Payne. She's a psychologist, and she actually works on dysmenorrhea in adolescent girls and the impact on mental health. And one of the things that concerns her and that she's researching is um, there's a high proportion of girls with severe dysmenorrhea, some of which is not responsive to NSAIDs, non-steroidal anti-inflammatory drugs. And one of her considerations is whether there's central sensitization to pain and how does that affect mental health, but also could that potentially also affect long-term vulnerability to chronic pain syndromes at some point if you're having very severe dysmenorrhea on a monthly basis that's non-treatable. And so she's actually about almost completing an R1 where she's been looking at this problem and doing neurobiological assessments and neuroimaging studies, and that work's just getting published right now. And in our community survey, she's actually inputted in a pain survey for us to take a look at, and some of the early results are pretty interesting, and that we've started to look at. So it's very pertinent. We have a long way to go to really understand all the implications throughout, the whole life course. So, thanks for the question.
So I think one of the things that you had a little bit of time to touch on, but it'd be great to hear more about, is with the women's recovery group. You mentioned that the manual's been out for a while, and you've heard about sort of dissemination and uptake. It'd be great to hear reflections on that, and I suppose it's kind of living and breathing out there in the world. We're also really interested, I think, from an Australian context, where it's being used as well. We have a fairly diverse kind of health workforce across kind of outpatient treatment settings, AOD settings. What your reflections are in terms of who can run this program? Where could it be run? Where do you see that?
Yeah. Well, I think it's meant to be a pretty flexible group treatment, and we have always had it run with professional staff, but across many, many disciplines of professional staff, from counselors to social workers, psychologists. We've had a few psychiatrists run it, so it's pretty flexible in terms of who can actually be the group leader. We've trained a lot of people, at McLean to run it. We train fellows; they, co-lead the group with others. Many of them are not addiction trained people. We've had our women's mental health fellows learn how to learn how to do it. From my perspective, I don't track who's implemented it where, but when I do go around and give talks, people do come up to me and say they've implemented it in a wide variety of treatment settings, outpatient treatment settings, in multiple different kinds of community-based treatment programs. For example, people who are being reintegrated into the community after being in a carceral setting, to multiple different communities across different races and ethnicities. So we think about it in a pretty flexible way, and the manual is made to be flexible, so that there are 14 topics. We say at the beginning of the manual, you can choose 12, which in the US is usually what is funded in terms of insurance reimbursement. Or if you're able to run all 14, you can run all 14. Or let's say it's in an outpatient clinic that's trauma focused. Well, if you're already doing that, you would eliminate the trauma module because you're already doing it, so you don't need to do that. Or if you're sitting there with 18 to 24-year-olds, you might take out some of the things that really focus more on women through the entire lifespan, because you don't have adult women who are in their 60s and 70s in the room. We had that in there because we originally wanted it to be a take all comers kind of program, so that if you were a setting that had like 8 people age 18 up all the way through older age, and they were across generations, we wanted to encompass information that would cross the generations. But if you're just, if you're, working with a college age population, you don't need that module. You would, not use that module. So there's instructions in there to help, guide clinicians about how you might implement it in different settings. At McLean, we've had this running in an eating disorders residential treatment program for young women with eating disorders. It's been running. We published a paper on that. It's been running, I think, for 10 years or 8 years in that setting, because we have a lot of young women with co-occurring eating and substance use disorders. And so they run it as a component of care. So there's a lot of different, it's meant to be flexible, and it's also meant to take into account different levels of health literacy and literacy in general. The take-home messages are meant to be aimed at about what we think of as an eighth grade literacy level. And so, but a lot of the handouts have a whole range of information so that it could hopefully address people's needs for information across even a diverse level of education as well. So it is meant to be really flexible and for people to be able to implement it, in a variety of settings.
Thank you for that answer. I think we've got a couple of questions coming through on the
Yeah.
Q&A as well. And one point was around sort of family violence. So in Victoria and across in Australia as well, in many jurisdictions, we've had a range of kind of reforms around family violence and trying to figure out how we can adapt treatment to be able to, identify and support women in violent relationships. And I think one of the things that was really kind of interesting with the phase 2, 3 trial as well that you were talking about is that family violence module that's in there as well in the information. And so one of the questions was around how is that information kind of delivered within the women's recovery group, and also the difference between the women's recovery group and the mixed gender, how that's actually played out in terms of how that information is translated.
Yeah.
Yeah.
Thanks. Yeah, that's a great question. The mixed gender group drug counseling condition, which you can look up, it was used in the cocaine collaborative trial for NIDA, and we used it as a mixed gender condition because it's a very standard counseling program. It really focuses on a lot of the things that we focus on in treatment, such as high risk situations, managing those, using self help, and a whole range of things. There is no gender specific information. There isn't information about some of the things you were just asking about, Shalini, like about violence. There's nothing that's gender specific either for men or for women. It's really focused on relapse prevention in a standard counseling condition. And as I said, it's a highly effective counseling program, and it's why we used it because it doesn't actually have any gender specific content at all, and it does not address trauma. It doesn't address co-occurring depression, anxiety, any of these um, uh, any of these conditions that we know are disproportionately high in women, which doesn't mean that men also don't have them. So it's in the mixed gender condition that is not part of it. In the women's recovery group, we have a module on violence and abuse getting help, and it runs through the things that I think most of you would know about, which is to talk about what can happen, what does happen, to talk about, people if they are in a current situation, how they might get to be in a safe place if that's needed, if it's been part of their past, meaning that they've had childhood abuse, they've had sexual assault, et cetera. It's meant to talk about that. It's also meant to talk about some of the downstream trauma related consequences, such as PTSD and other things. And we also say that, for each of these things, every part of the women's recovery group also talks about getting other co-occurring treatment as you might need it. So, for example, for women in the module that's on depression, anxiety, and eating problems, that really talks about the need for co-occurring treatment for those disorders. So, how do you get help? Where would you turn to help? Do you need pharmacotherapy? Do you need another, behavioral intervention for depression or anxiety? Similarly, for violence and abuse and trauma and co-occurring trauma related disorders for women who need that, we would, in that module, there is discussion about what kinds of treatments are available. And obviously or maybe it's not obvious, but the therapist would be hopefully connected in a way that they would, in fact, as they needed to, connect people to additional care. So it's not meant to itself be a trauma related um, treatment, but it is meant to surface what's necessary for the women who are in the women's recovery group to make sure that they do, in fact, get the co-occurring other treatments that they need.
That's really helpful. We might take one last question from our online audience. So we've got a question here about sort of menopause and perimenopause, and you touched on that during a talk. And the question was really around what do we understand, I think, about the impact of alcohol at that perimenopause, menopause phase in this older age cohort.
Well, that's a great question too. It's not fully my area of expertise, to talk about that. But what I would say is we do, in fact, know that it varies a lot with the population. We know that also it's hard to, there are not really great studies that really have assessed menopause, perimenopause, and drinking and alcohol use disorders per se. So, in fact, we know that there are changes in drinking patterns through the age span, but the degree to which, let's say, somebody in perimenopause or menopause would actually attribute, for example, um, their drinking or change in drinking to menopause or perimenopause as opposed to another reason or cause, we don't know. We are actually trying to get at some of that right now in the community-based study that we just fielded, in terms of asking people about why they are actually using any of the substances you're using, alcohol or cannabis. So that's one thing. The second thing is, I think it's in fact true that in general, when people, we know this is true for women and men, when people are suffering from certain things where they are not able to gain treatment that relieves symptoms, people will, in fact, turn to things that they have that are readily accessible to them to help themselves or to try to help themselves relieve symptoms. So I think it is, in fact, the case that, when people are not able to sleep, for example, and they don't have, due to perimenopause, as just one example, it would not be a big leap to think that there would be people for whom they're trying to just assist themselves in relieving symptoms. And this may be one way that people might turn to that. And of course, one of the things we hope for is that we can help people, have the type of treatments that do alleviate symptoms that they have, especially, perimenopause can be like a 10-year situation for a lot of women going through transition. And that's a very long time to have symptoms. We also know that for some women, not all, there's some onset of depression, major depression that can happen at that period of time. And we also know that women sometimes will use alcohol for that. So, there's a lot of different related areas. As I said, what we hope for is that we can actually get people into a situation where they can actually be treated for the thing that they're suffering from, as opposed to reaching for things that they're just trying to alleviate something that for which they don't have other forms of relief. So, I think they're can be very connected. And again, I just point out that I don't think we have enough information that we really need to really assist people. So thanks for that question.
Thank you. Thank you, Shelley. And I think thank you for the whole of the talk, I think, as well, really highlighting and a lot of work that helps with closing the gap, as you said, but also there's a huge amount of literature gaps that still exist and evidence gaps that still exist for women's health and substance use. So really thank you for sharing your work with us here. And thank you from us here in the room as well as online. For those of us joining online, just be aware that the presentation is recorded. It will be available to view on the Turning Point website in the next week or two. And if you subscribe to our mailing list, you'll be notified when the recordings go up live. So thank you for joining us, and we'll draw that to a close.